the world. Today we have got 3 lectures. The first lecture is on belumosudil in chronic GVHD, a new pathway to control fibrosis and inflammation, which is supported by Sanofi. And this lecture will be by Dr. Mallikarjun Kalashetty. Followed by we have got the panel discussion with our moderator, Dr. Ganesh Jaishetwar, and our panelists, Dr. Mallikarjun, Dr. Ragesh Nair, and Dr. Subramanian Kannan. The second lecture will be by Dr. Mohammad Rizwan Sheikh on intensive chemotherapy with venetoclax in newly diagnosed acute myeloid leukemia. And the third lecture is by Dr. Sunil Jondale on approach to bone marrow failure syndrome. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Perfect Square. And this has been supported by Sanofi, Nirvain Life Sciences, Natco, Lucien, and Unipath, and very well managed by Perfect Square. I thank team Sanofi, Natco, Unipath, Lucien, and Nirvain, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for the day, Dr. Mallikarjun Kalashetty, Dr. Ganesh Jaishetwar, Dr. Ragesh Nair, Dr. Subramanian Kannan, Dr. Mohammad Rizwan Sheikh, and Dr. Sunil Jondale. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon for whichever part of the world you're logged in. Let me introduce our discussants for the day, and they are well displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. For very eminent hematologists, hemato-oncologists, as well as medical oncologists all across the country. So these are our discussions for the day. And now let's begin with the part 1 of our MHG webinar today. And this session, as I told, is sponsored by Sanofi. The agenda is very clear. The subject is on belumosudil in chronic GVHD, a new pathway to control fibrosis and inflammation. This is being talked by Dr. Mallikarjun Kalashetty from Bangalore. And then we have the panel discussion with our moderator, Dr. Ganesh Jaishetwar from Hyderabad, and our panelist, namely Dr. Mallikarjun from Bangalore, Dr. Ragesh Nair from Calicut, and Dr. Subramanian Kannan from Pune. So this is our faculty, and I request Dr. Mallikarjun Kalashetty to please proceed with the lecture.
Somebody will have to allow me to share my slide, please.
Yes. You can share your slide.
Okay. My slides are in the slide mode, Dr. Amit. Yeah.
Perfect. Please go ahead.
Yeah. Good evening, everyone. At the outset, I thank Dr. Amit, the MHG Group, the Sanofi Group for this opportunity. For the next few minutes, I'm going to go through this presentation on belumosudil. I must also thank the medical team of Sanofi for this opportunity and also having shared these slides. So this will be a brief presentation on belumosudil in chronic GVHD, which is something exciting and all of us have been waiting to hear for. So this is a disclaimer from the Sanofi Group. So we all know the bone marrow transplantation across India have been increasing. There are newer centers every year, and there are more and more transplants being done, and rightly so for a country of our size and population with a host of illnesses requiring allogenic bone marrow transplantation, autologous bone marrow transplantation, and also the haploid identical transplantation. What is very evident in this slide is there's been a significant rise in the number of haploid identical transplantation, in fact, every year, which also means there will be more and more patients having graft versus host disease because of the kind of graft that we all use. So graft versus host disease is one of the significant issues that can occur post-transplant. And conventionally, we have classified graft versus host disease into acute graft versus host disease, which occurs within 100 days of transplant, chronic graft versus host disease, which typically presents beyond 100 days, However, now we have moved away from this time frame limited classification of GVHD, and we now classify more based on the clinical features and pathogenesis. So, acute GVHD typically affects the skin, the GI system, and the liver. On the contrary, the chronic GVHD can affect almost any organ and every organ in the body. Sometimes patients may develop a delayed acute GVHD, and we know this is a new way of classifying it, not just based on the time frame of strict 100 days. And why is it important for us to discuss about graft-versus-host disease? Because it is an important cause of mortality and morbidity post-transplant, and it can occur very soon if somebody has a bad steroid-refractory acute GVHD, or it can significantly affect the quality of life and lead to a lot of morbidity, affect the quality of life of patient when they have chronic GVHD. As you can see from these pie charts, GVHD accounts for about 13% mortality in HLA sibling donor transplant, and about 11% in unrelated, which is curious though. So we know chronic GVHD develops in about 30 to 70% of patients who have undergone allogenic BMT, and that 40% of them do have a severe disease at the time of diagnosis, needing initiation of systemic immunosuppressive therapies. And the chronic GVHD incidence has been increasing, I think partly at least because of increase in haplo and other mismatch transplant. And overall, 66% of patients with chronic GVHD would have had an acute GVHD. Now, we all know that patients who develop acute GVHD are at higher risk of developing chronic GVHD, and almost two-thirds of patients who have had chronic GVHD would have had some acute GVHD in the past. The established risk factors for development of chronic GVHD is number one, previous acute GVHD, gender mismatch transplant, more so multiparous female donor for a male recipient, older age of the recipient or donor, peripheral blood versus marrow graft. We know more the HLA disparity, more is the risk of GVHD, and of course the measures which are known to mitigate GVHD, like T cell depletion, would reduce the risk of GVHD. However, the PTCY or T replete transplant can lead to increased risk of GVHD. We know chronic GVHD essentially has an early inflammatory phase wherein the immune cells lead to activation of T cell secreting alloreactive T cells. That initially might be more important in the pathophysiology of acute GVHD. Persistence of these chronic inflammation and increase in the fibrosis as an effect of chronic inflammation are the hallmarks of chronic GVHD. We know that chronic GVHD has more heterogeneous presentation and can involve any or every organ, notably skin, nails, scalp, mouth, eyes, GI tract, genitalia, lungs, liver, fascia, and joints. It is characterized by fibrosis, inflammation. Fibrosis is indeed one of the major contributor of life-threatening complications of chronic GVHD. And also the chronic GVHD onset in many patients may present initially a skin rash in mouth, dryness and sensitivity, foreign body sensation in the eyes, and there can be symptom progression in these organs, and that may lead to skin sclerosis, oral ulceration, severe dry eyes, and involvement of other organs like lungs in the form of bronchiolitis obliterans. And once that happens, it could indeed be very difficult to treat these patients. We know chronic graft-versus-host disease significantly affects the quality of life of a patient. It may not be as dramatic as an acute GVHD is. However, it can affect host of quality of life related issues like physical functioning, uh, the bodily aches and pains, the general health, the vitality, the social functioning. So all of those can indeed be affected because of untreated chronic GVHD. In terms of the organs involved, skin, mouth, and eyes are the common ones. Lower and upper GI tract are involved in almost 20 to 30% of patients, liver and lungs in about 20% patients, and joint and fascia and upper GI involvement is in about 10 to 20% of patients of chronic graft-versus-host disease. I think all of us have gone through these. Some patients may have diagnostic feature, meaning the feature themselves are enough to establish diagnosis of chronic GVHD and do not require additional testing or biopsies. Distinctive features are the ones which are not typically found in acute GVHD but do require additional biopsy. Other features which are unclassified or atypical could be rare, and they could be non-specific and cannot be used as standalone features for defining chronic GVHD. and there are certain atypical features which can be shared by both chronic and acute GVHD. So diagnosis of chronic GVHD requires the presence of more than one diagnostic feature or more than one distinctive feature plus an additional testing like biopsy. So we also know that there is a grading system to grade the severity of chronic GVHD, which oftentimes can be time consuming and labor intense, or can be very useful in treating these patients and also following them up with the treatment. So it is based on the organ involvement, the severity of the organ involvement, and the number of organs involved, and is classified into mild chronic GVHD, moderate chronic GVHD, and severe chronic GVHD. A host of GVHD prophylaxis have been used for patients of allogeneic bone marrow transplantation, and we know that GVHD indeed remains one of the formidable barrier for a successful allogeneic bone marrow transplantation, and it could be because of the acute and chronic GVHD, despite the host of uh, GVHD prophylaxis measures that we use during the transplant. When we treat chronic GVHD, we know there is varied therapy, but most commonly the first line of therapy is systemic steroids with or without the CNIs that we use as a part of GVHD prophylaxis. Second line treatment is used, may be required for almost two-thirds of 70% of patients of chronic GVHD, and we'll get to which are the agents that we use. And third line would be used in about half the patients who have chronic GVHD. So, based on the treatment consensus recommendations, the first line of treatment usually are systemic corticosteroids, dexamethasone or prednisolone, and oftentimes these patients are also on tacrolimus or cyclosporin. The preferred second-line agents are ruxolitinib, ibrutinib, and imatinib, and one may decide to add on the other agents based on the patient's response and the severity of chronic GVHD. We do not have a standard third-line treatment for these patients, and oftentimes patients are on more than one line of agent depending on the physician preference and where they are used. The key molecular pathway in chronic GVHD are the ROCK-STAT, JAK-STAT, IL-2 pathway. The ROCK molecular pathway plays a key role in both immune and fibrotic disease. More so, the ROCK2 specifically involved in both inflammatory fibrotic components of chronic GVHD and has been shown to play a vital role in modulating the immune homeostasis. BTK signaling is indeed very important for B cell related events, and signaling via BTK results in activation of pathways that are necessary for both B cell trafficking, chemotaxis, and adhesion. JAK-STAT pathway is indeed very important in chronic GVHD, and it regulates development, proliferation, and activation of various immune cells. And interleukin 2 mediated cytokine signaling is essential for normal Treg development, expansion activity, and survival of CD4 cells. Impaired Treg function is characteristic of chronic graft-versus-host disease, and that is associated with loss of immune tolerance and autoimmunity. So ROCK2 inhibition with belumosudil is the newer agent that we will, of course, be using more and more in future. So it's a selective ROCK2 inhibitor, which leads to two important things. It leads to downregulation of pro-inflammatory TH17 cells and increases the Tregs, thus rebalancing the immune system and reducing inflammation and fibrosis. We know ROCK regulates multiple profibrotic fibrosis, including myeloblast activation. ROCK is a downstream of major profibrotic mediators. It mediates stress fiber formation and also leads to transcription of profibrotic genes. Hence, it has been very elegantly studied that the usage of belumosudil as the first and perhaps the only approved therapy of inhibiting ROCK2 targets both inflammatory and fibrotic pathways of chronic GVHD. It leads to decreased activation of STAT3, triggering significant downregulation of both TH17 and T follicular helper cells, leading to downregulation of pro-inflammatory cytokines. It increases the phosphorylation of STAT5, causing upregulation of Treg cells. This leads to immunomodulatory effect and reducing inflammation. It also reduces the fibrosis by preventing the polymerization of G-actin to F-actin, including the downregulation of MRTF-related pro-fibrotic gene expression. It downregulates fibrosis and reduces the collagen deposition around the bronchioles and delays the progression of scleroderma, at least in animal GVHD molecules. So those are the different ways in which belumosudil is likely to help patients of chronic GVHD. Based on the approval attained, it is indicated for the treatment of adult and pediatric patients about 12 years and older with chronic GVHD after failure of at least 2 prior lines of systemic therapy, typically used as 200 milligram once a day, approximately at the same time after meal. And treatment should continue until progression of that requires new systemic therapy. It is the first-in-class small molecule inhibitor of ROCK pathway. And as selective ROCK2 inhibitor, it has 100-fold higher inhibitory activity against ROCK2 compared to ROCK1. It simultaneously targets both inflammatory and fibrotic components of chronic GVHD. It reestablishes the immune homeostasis and regulates profibrotic processes to address underlying pathophysiologic drivers of chronic GVHD. If you look at the impact of ROCK2 inhibition on chronic GVHD with inflammation and fibrosis, it inhibits abnormal immune activity and inflammation, shifts Th17 Treg balance towards Tregs, restoration of immune homeostasis is thus attained. It also inhibits the fibrosis and inhibits the profibrotic pathways. It reduces the inflammatory cytokines. The consequent immunomodulatory effect of STAT3 and 5 phosphorylation restores the immune homeostasis, thus reducing inflammation in chronic GVHD. So the first line treatment of chronic GVHD often involves systemic steroids, as we all have used for a long time. And these are broad immunosuppressive agents without specifically targeting an underlying pro-fibrotic processes. Velomostil, however, selectively inhibits the ROCK2 and inhibits the pro-fibrotic process of chronic GVHD. It prevents the polymerization of G-actin factor, as we have seen, and prevents the MRTF-induced upregulation of pro-fibrotic gene expression. This results in the ability of belumostil to downregulate the fibrotic processes associated with chronic GVHD. The pivotal Rockstar study looked at patients who are older than 12 years, underwent an allogenic transplantation, had active chronic GVHD, had received more than 2 to 5 prior lines of systemic therapy for GVHD. Systemic therapy for GVHD is indeed indicated based on the severity, and those were risk stratified based on the prior ibrutinib exposure and severity of chronic GVHD. Arm A patient received belumostil 200 milligram once a day. Arm B patients received 200 mg twice a day, and the primary endpoint was best overall response at any time during 12 months according to 2014 NIH GVHD consensus criteria. The secondary endpoints were safety, duration of response, time to relapse, CS and CNI doses, FFS, OS, and response by organ system. And if you see, belumostil achieved a clinically meaningful, significant oral response of 74% in these patients, which is a very impressive response rate indeed in those patients who are heavily pretreated. And 200 milligram once daily dosage, oral response rate, if you see, CR was in 5.2 and PR was in 69% of patients. So clinically meaningful oral response rate observed across key subgroups. If you were to look at 200 mg once daily, early CGHD diagnosis, severity, all of that, the response rates are more than 70%. Even in those patients who had more than 4 organs involved at the baseline, the response rates were 70%. More than 3 prior lines of therapy, the response was 67%. Refractory to last line of treatment, again, the response rates, if you look at the overall response rates, were really impressive in patients who have received prior systemic therapies. Look at this cartoon. If you see, the organ responses were very good in skin, eyes, mouth, joints, and fascia, as could be explained based on the mechanism of action of belumosudil. However, the response rates were little low in patients who had lung, liver, and lower GI involvement. Most response were seen between 4 to 8 weeks, which means response were very early in these patients who have chronic GVHD, and 94% of response were seen by week 24. And median time to first response was 4.43 weeks. So if you look at the FFS rate, it was very impressive at 48% at 18 months and 43% at 2 years, really. So that is very impressive. The only issue is these patients will have to continue this treatment for a long time, and that is something that could be a little tricky for our patients. Overall survival rates with belumosudil, if you look at, were very impressive indeed. And mind you, these were the patients who had either had steroid refractory or steroid dependent patient, and the 2-year overall survival rate of 85% in this patient subgroup is very impressive indeed. If you look at this data, 58.4% of patients achieved a more than 7-point reduction in the quality of life score with 200 mg once a day. Both responders and non-responders had improved quality of life scores. Um, if you look at the reduction in the use of the CNI therapies, which is one of the secondary endpoint, patients dose reduction was seen in almost 77 patients, and CNI therapy reduction in 58% patients. Discontinuation rates are also impressive in 27% and 28%. So median percentage of dose reduction was maximum 50% in patients who received belmosudil 200 mg once a day. So belumosudil indeed is well tolerated in patients with chronic GVHD in both clinical studies. The fatal adverse reactions observed in only one patient had severe nausea, vomiting, diarrhea, and multi-organ failure. Permanent discussion of belumosudil due to adverse reactions was seen in 18% of patients. The adverse reaction which resulted in permanent discontinuation in more than 3% of patients, including nausea. The most common adverse reactions were transaminitis, laboratory abnormalities, infections, asthenia, nausea, diarrhea, dyspnea, cough, and edema. There are no reports of CMV infection either in the Rockstar or the other studies, and there was only one report of CMV reactivation in total in the Rockstar and the KDO 25208 studies. Grade 3 or more cytopenia were reported in less than 4% of the patients. So this is not very myelosuppressive, easy to administer orally, and most patients tolerated this without significant toxicity. So belumosudil for chronic GVHD after 2 or more prior systemic lines of therapy, if you look at the 3-year follow-up of the study, the overall response rate again is very impressive. It's clinically meaningful and improves the quality of life. 74% with once daily and 76% with twice daily. So once daily dose is something that can be used with very impressive response. So failure-free survival also, as you can see in this cartoon, for this heavily treated patient of almost 40 to 45% is indeed very impressive. So 44.1% was observed in intention to treat population, 51.8% was observed in responder population. Again, this is an update which was there in the EBMT guideline 2024. In adults with steroid refractory chronic GVHD, belumosudil is a potential therapeutic option, and it has indeed encouraging overall response rates, well tolerated, not myelosuppressive. And a subgroup consideration was that the patient at risk of infection or cytopenia might benefit more, as this is not myelosuppressive, does not worsen cytopenia compared to the other systemic immunosuppressive agents that we use. So that is subgroup of patients wherein you cannot use other immunosuppressive modalities. I think belumosudil can be used pretty safely. So I think I'll stop there and hand over the podium back to Dr. Amit. I'll stop sharing now.
Thank you, Dr. Mallikarjun. Wonderful lecture, very crystal clear. And now we'll move out to Dr. Ganesh Jeshetwar, who is a moderator for the next panel discussion. So, Dr. Ganesh, the screen is yours. Please go ahead.
Thank you so much, Dr. Amit, for the kind introduction. And thank you, Mallikarjun, for setting the context so beautifully. So we all know that chronic GVHD doesn't just scar organs, it quietly scars lives, movements, breath, sleep, even the way a patient holds their child. So today we are here to ask a very hopeful question. Can volumetricidil, by targeting fibrosis and inflammation together, finally change that story at the bedside, as the number of transplants across our country are rapidly shooting up? I hope my slide deck is visible and I'm audible.
Yes, very clear. Please go ahead.
So my job, thank you, Mallikarjun, for simplifying the data, the complex data in such a crisp, precise way. So let us start the panel discussion. So I will request my eminent panelist, Dr. Mallikarjun, my close friend, to stay On board Dr. Kannan Subramaniam sir and Dr. Ragesh Nair. Dr. Kannan Subramaniam is a friend and a senior consultant hematologist at Sahyadri Super Specialty Hospital and uh, um, KEM Hospital Pune, and Dr. Ragesh Nair. So all three of them are on board.
Yes.
Yes.
Thank you. So, as you know, this is the disclaimer. This is a sponsored virtual webinar sponsored by Sanofi. Thank you, Sanofi, for bringing all of us together on such a burning issue in our transplant spectrum. So, this is what Mallikarjun was highlighting: the spectrum and manifestations of chronic GVHD. You can see that notably involved organs are skin, eyes, mouth. The other organs are liver, lung. So fibrosis because of the long-term inflammation, and this is the inflammation fibrosis eventually leads to irreversible organ damage, eventually leading to the poor quality of life. And this is the GVHD prophylaxis over time, thanks to the breakthrough PTCY in 2008. And its application not just in the alternative donor transplant, even in the mass sibling transplant, the outcomes are phenomenally increasing. And you can see this CIBMTR data set, the incidence, cumulative incidence of chronic GVHD is declining, and more so from the recent CAST trial, as well as the CIBMTR data set, where PTCY is rapidly and more commonly being integrated into the mass sibling transplants. Also, the incidence is supposed to get down further. So even with PTCY ATG backbone, the incidence of chronic GVHD is still significant. You can see the incidence at 1 year 28% and can go up to 42% at 4 years timeline. And this is the experience and the perceived success with 15 most common immunosuppressive therapies in chronic GVHD, none of them crossing the bar of 20% meaningful responses. And not only that, so the common organs involved, you can see skin, mouth, eyes, gut, and liver. And almost 30% cases, three or more organs are involved. And the intensity of problems, you can see the prognostic factor, severity, steroid dependence or refractoriness, number of lines of treatment, and most notably lung and skin sclerotic forms. So essentially, after 5 years, one-third patients succumb to chronic GVHD or chronic GVHD related complications. Almost one-third required continued immunosuppressive therapies, and thereby various complications, infections, and other organ dysfunctions because of the continued immunosuppressive therapy. And only about one-third are off immunosuppression at a 5 year time point. So this leads to cumulative TRM up to 40%. And the good news, over last, just starting from 2017, there are three breakthrough interventions in chronic GVHD, starting free to ibrutinib in 2017, ruxolitinib in 2019, belumosudil in 2021, and axatilimab is investigational, and there are ongoing trials. So this is Mallikarjun has highlighted. So lymphocyte activation kinases and thereby breakthrough therapeutic interventions. So the biological components are active inflammation, chronic inflammation leading to subsequent chronic inflammation, dysregulated repair, and the third phase collagen deposition and fibrosis. And in this context, these are the various therapeutic interventions. You can see here belumosudil very effective in both component 2 and component 3, reversing collagen deposition and fibrosis. You can see the other therapeutic intervention, axatilimab, is also found to be in a short clinical cohorts effective in the collagen deposition and fibrosis. So in this context, I will start with Mallikarjun. Who do you say steroid refractory versus steroid dependent, and who gets the belumosudil first in your algorithm in chronic GVHD in your cohorts? Dr. Mallikarjun.
So I think the definition is fairly clear in acute GVHD. However, in chronic GVHD, we still have to work on it. But largely, those patients who received more than 0.5 milligram per kg of steroid and have not had response for up to 2 weeks are termed steroid refractory. And those who have recurring symptoms on tapering steroid are obviously steroid dependent. And amongst these who would get the belumosudil first, so I would say the approval now is steroids and another line of treatment before we bring in belumosudil. However, there are certain patient subsets where you would want to use it first based on the clinical discretion, somebody having severe cytopenia, somebody wherein immunosuppression is a concern.
Yes. So, as I highlighted earlier, 30% continued immunosuppression, 30% succumbing to chronic GVHD, and only one third of them responding first, second, third line. So, in this context, this lymphocyte activation kinase inhibitors, most notably bolumicidil, these are the top six papers we all of us should know who are active in stem cell allogenic stem cell transplant. Rockstar, the Blood 2021 publication, Malikarjun has detailedly highlighted. ASCO JCO 2021 publication, PENAC, the EBMT recommendations published in Lancet Hematology about the chronic GVHD management, and the evolving NCCN stem cell transplant guidelines, and this recent ASH publication on Blood Advances 2025 about the phenomenal outcomes of the oral chronic GVHD with belumicidil, and again a real world BMT 2025 publication. So this is in nutshell belumicidil in chronic GVHD. As Malikarjun was highlighting, these are the three trials. You can see the overall response rate ranging between 70 to 85%, and the dose now zero down is 200 mg daily. You can see the least score of chronic GVHD improvement seen in 50 to 65%, and the most important failure free rate is exceeding 75% at 6 months. And you can see in the Inamoto Japanese data, the failure free rate was 95%. So again, I will ask Dr. Ragesh, which type of chronic GVHD is most difficult to treat, skin, ocular, gut, or lung?
So, I mean, for patient who gets any of them, they find it difficult. But however, anybody who has a established lung GVHD, it is
Yes.
quite difficult. It slowly keeps on progressing unless we initiate FAM treatment. Also, then also it keeps on progressing. And of all of the GVHD is the one which can result in significant morbidity. But of course, mortality is probably lung. So I
Yes.
find lung more difficult to treat, and even in lung also there is not much data for long-term steroid use also as well, unlike others.
Yes.
So I feel lung is
So,
the most dangerous, but all others are
absolutely.
also very irritant to the patients.
Absolutely, Dr. Ragesh. As highlighted in the chronic GVHD severity as well as scoring, so it all depends on the extent of number of organs involved, the severity in each organ. So that reflecting in mild chronic GVHD is without lung, any organ, one or two with grade one. Moderate is lung one and other three or more organs, or two or more organs with two score, and whereas the severe is lung 2 3 4 and other organs severe involvement. So, and I skipped that slide, but I had many cases, but I thought for the interest of time, let us discuss the burning issues rather than focusing each individual case. So the most notable, as Ragesh mentioned, in the lung chronic GVHD, by the time there is decrement in the FEV1, already 50% of the lung, the bronchi, and the airway fibrosis has already established, and whatever therapeutic intervention, the irreparable damage has happened. So that's, and the involvement of lung is again notoriously detrimental in the patient's quality of life. So Dr. Kannan sir, what are the current treatment benefits and challenges for chronic GVHD?
Uh, okay, so all of us know that it causes lots of morbidity and mortality, and there are also papers to suggest that how you actually qualify the responses according to you and according to the patients actually is much different. The patients actually don't qualify the responses in chronic GVHD as good or in that grade compared to what you would grade as good. So the perception of the patient also becomes important when you are treating your GVHD. And as we know, like Mallikarjun told, we still start with steroids, look at the response, and then
Yes.
of course steroid has its own sort of set of problems in terms of increased sugars, increased infection, AVN, when we give it for a longer time versus and then you go on to steroid refractory, where again there are bigger challenges. At this point of time, I think we have only Jakavi as a more effective therapy. So if you have beyond Jakavi, previously there were very few interventions which were equally effective. So Belumosudil gives us sort of another uh, thing that we can intervene with in this group of patients. And again, when you look at how when you are monitoring these patients, it's not easy and simple. It has to be a detailed evaluation of these patients in terms of the kind of organ systems that get involved and to the degree that will get involved. So say skin, mouth, the joints, thickening of the skin, the sclerosis, the fibrosis, all of them will need to be taken into account when you are grading and looking at your patients, uh, as well as say lung symptoms, the DLCO, the changes, and then when you intervene with whatever you're doing, you need to sort of also assess the duration taken for a response and the degree of the response that you would uh, get in these patients. So there are multiple challenges in treating chronic GVHD patients.
I just putting it other way, Kannan sir. So what I was referring again, a continuation of the same extensive skin involvement, musculoskeletal or facial involvement. Will you like to start steroid monotherapy alone and then eventually build on based on the response, or given the proven efficacy, particularly in the skin and oral extensive chronic GVHD, will you be tilted to add on such anti-fibrotic as well as anti-inflammatory combined therapeutic
Obviously,
benefit of belumicidil
obviously,
on
at
the
this point of time, if you look at even the skin GVHD, chronic GVHD with its sclerosing and fibrosing forms, um, effective therapy, of course, when you don't respond to steroids, will be uh, the UVA therapies, no?
yes, ultraviolet.
Correct.
Yes, sir. Yes.
And apart from that, I think in this group, obviously, Belminocidil seems to be working wonders in terms of acting on the fibrosed patients also.
Yes. So, extension of the same question. So, Dr. Ragesh, based on the data we discussed, Dr. Mallikarjun highlighted, who in your practice will be an ideal patient for belumicidil, like the standard recommendation failure of 3 or more lines in chronic GVHD with extent of organ involved, the particular organ preference. So, Dr. Ragesh, your thoughts and inputs on this.
So, in my practice, I mean, since there is data to show that upfront combination therapy with steroid with some other agent like cyclosporin, MMF, or many others have not been so successful, I would continue steroid. Then, if it doesn't work, I would add ruxolitinib or ibrutinib. Then, even then, if the scores don't go down, the severity of the organ scores doesn't go down, I would add belumosudil. Uh, uh, but if a patient who has a GI issue or a liver issue, in general, the outcomes with belumosudil are not good. So I would avoid them maybe for liver and GI use. But any other patient who is not responding well to this, I would definitely add belumosudil. Uh, of course, I mean, since it is one of the agents which has good action against the fibrotic pathway, I would be inclined to add upfront itself to the skin and oral GVSD and all, but on even lung GVSD as well. However, since there is no approval and
Oh,
since the PAP program may not support that, I would follow the FDA approvals as of now.
So, Dr. Malikarjun, about lung chronic GVHD, the utility of belumicidil as per your uh, presentation and the available literature data.
Dr. Ganesh, it's great to see you from the space. Couldn't see you in Bangalore. Your background is very, very interesting. With regards to lung, I think one of the expert has already alluded to. It is one of the worst forms of GVHD that we can see. I think across the board, various trials have showed that the organ response in terms of lung GVHD are very poor. We always start with the combination of steroids, the bronchodilators, azithromycin. However, I have had a patient who had an extensive GVHD of skin, eyes, the fascia, and also his lung GVHD was quite significant. So in him, who was already on steroid, on tacrolimus, on ruxolitinib, we did initiate belumosudil, and not just the skin and fascia, even the lung GVHD got significantly better, I think by week 6 to week 8, and he became oxygen independent. His endurance was much better. He was able to be much more mobile. So I think it has worked well in few patients that we have used. However, we are very mindful that lung GVHD is indeed the difficult one.
Yeah, so as Dr. Malikarjun highlighted, the data says the response rate to belumicidil in fibrotic, sclerotic lung GVHD is about 32%, 17% CR, 15% PR. This is very, very promising and encouraging data because none of the therapeutic interventions with regard to lung GVHD has shown such a good response, even though the response is not as per our expectations. As Dr. Malikarjun highlighted, the cases who have reversal or at least stabilization of lung functions with improvement in the oxygenation is really rewarding. And I think this is something where we will be inclined to combine belumicidil with other 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 lymphocyte kinase inhibitors, so like ibrutinib or ruxolitinib. So this is the forest plot of what Dr. Malikarjun suggested. You can see it favors and the response rate ranging between 60 to 70% across the group. So the all subjects severe chronic GVHD at screening, number of organs involved more than 4, less than 4, number of prior systemic therapies more than 4, less than 4, prior ibrutinib, prior ruxolitinib, and a concomitant PPI or the C1D1. So all the subsets benefited. So of course the phenotype fits for sclerotic skin, joint fascia, or lung uh, bronchiolitis obliterans syndrome. Definitely belumicidil seems promising against ruxolitinib as well as ibrutinib. And the data is not yet, there is no head-to-head comparison, of course, with ECP and all this, but it seems very interesting. And as you can see, the response rate as per the overall response rate by organ system in the intention to treat population, and you can see here the lungs is the last one, but still the 26% responses, of which 50-50 CR and PR, it is promising. Whereas the best responses are joint fascia, gut, upper and lower gut, mouth, and eyes. So again, this is the publication, recent Blood Advances 2025, 6 months of treatment with belumicidil. Belumicidil led to significant decrease in collagen as well as IL-17 in oral chronic GVHD. So, Dr. Kannan sir, what are your thoughts on combination therapies for first-line treatment of chronic GVHD based on the current evidence?
Okay. Generally, when you start with chronic GVHD, only when it is a grade 1 skin or oral GVHD, you would end up starting somebody on single agent. Anything more than moderate to severe chronic GVHD, you would probably use combination in steroids in addition to steroids plus maybe sirolimus or mycophenolate typically is what you would use, right? Only,
Absolutely.
only in the grade 1, maybe superficially you will apply steroid creams in skin GVHD. Otherwise, it's generally a combination that you would apply as this response, and then you would go. So, and you could combine with Jakavi, and based on the responses, then you probably will decrease the other immunomodulatory or immunosuppression drugs, right? So,
Perfect. Yes. So thank you so much, Dr. Kannan sir. So as you highlighted, and as I in earlier slide showed that the all the 15 immunosuppressants responses are less than 20%, and most of these require continued immunosuppression for a meaningful responses. I think the era coming ahead is a combination of these targeted drugs, which might be complementary to each other based on their unique mechanism of actions. And by combining these, of course, there is a theoretical risk of infections offshoot, but the conventional toxic ineffective immunosuppressants we can get away with. So again, this is a small data belumocidil ruxolitinib combination for the management of refractory chronic GVHD. This is recent blood advances publication. So almost 50% patients have a partial response and a stable disease, another 50, the total 50% patients. So you can see the severe 12 versus moderate 2. So all these are severe, and all of them have received prior targeted drugs, and this combination has at least 50% patients meaningful responses. So based on the data presented, Dr. Ragesh, what do you see as an optimal positioning of belumosudil in the treatment algorithm for chronic GVHD as per the guidelines and recommendations, third line, fourth line, or are you going to prefer it a little upper in the ladder for depending upon the extent as well as the number of organs or specific organs involved in chronic GVHD?
I would, I mean, if money is not an issue, I would like to actually start off in combination therapies, especially when you have lung GVHD, I mean, chronic GVHD, or skin GVHD, etc. Because probably it doesn't add much of to infection. The past
Yes.
data where the combination of steroids and other agents like MMF and all were used, there was no clear advantage of combination therapy. But
Yes.
that data was the with the combination of older immunosuppressant. But in the first line, I don't think any trial has been done with combination of steroid plus belimosudil, or I mean, not much of data combination with ruxolitinib as well. But if there is data, or and if cost comes down when we don't have to look for a PAP program, I would definitely may combine in upfront itself with all forms of GVHD. But there is some data. I think
Yes.
the Rockstar data showed that GI tract involvement, the overall responses rates are low. But I think there is some other data that it is also good. But the first data was that GI tract outcomes are not so good. I mean, as far as I remember in the Rockstar data, and all other patients, I would like
Yes.
to start belimosudil if cost is not an issue, and uh,
Yeah.
and it is on only once
Dr. Ragesh, as you highlight, yes, yes.
and since it's only
As
once
you
daily,
highlighted,
yeah.
yes, yeah. Please go ahead.
And since it's simple once daily tablet, I mean, 200 mg once daily, it is, I mean, adherence is also good. And in that also, there was not much of CMV or fungal infections and all. So,
Yes.
yes.
So, as is the rule in hematology, hemato-oncology, and stem cell transplant, any newer therapeutic interventions first is tested in the multi-drug refractory latter
Yeah.
lines of therapy, and based on the promising results, it slowly climbs up the indications, and eventually, if it sustains the test of time, it becomes one of the upfront recommendation. And I hope and really wish this should also be the scenario with belumosudil in our chronic GVHD spectrum. So, Dr. Mallikarjun, What are the safety considerations when using belumicidil in patients with multi-organ involvement or comorbidities? So like cardiac, renal, hepatic impairment. So risk stratification and monitoring. So is there any concern to be little particular or cautious about adding this belumicidil in these patients with these issues?
Yeah. So not that I can talk from the personal experience, but by the review of literature really, because we have used it in one or two patients only. I think the concern is if the patient has severe hepatic impairment, then it can be a challenge in using these patients. Patients with profuse GI symptoms could be a challenge. Otherwise, largely cytopenia, bad infection are not such a big challenge because it's not a very myelosuppressive agent. So I would think severe, liver dysfunction is one of the major impairment, major uh, uh, roadblock for the usage of this agent.
Perfect. So again, this is the thank you so much, Dr. Malika. Again, this is the same question we discussed earlier. Belumicidil as a steroid sparing agent added earlier in the therapeutic armamentarium of chronic GVHD management. So anybody has anything to share thoughts on this dose reducing effect of belumicidil in terms of in patients with steroid dependence?
So we think at least conceptually those patients who have significant skin, significant joint fascia, skeletal muscle involvement, restriction of movement. I think in these are the group of patients who are likely to benefit. And also you would think again conceptually, since there was no severe CME reactivation, bad life-threatening infections, using it long term could be, I mean, fairly okay. Apart from the financial toxins that one may have to be mindful of in patients who have to pay out of their pocket. So I would think, like you rightly mentioned, this is likely to be used sooner than later.
Yes, thank you. So again, continuation of the same question to Dr. Ragesh and Dr. Kannan sir. Do you track quality of life as Dr. Kannan was mentioning, GRFS like composite endpoints? As we all know and we all agree that GRFS has changed the way we look at the allogenic stem cell transplant success. Previously, OS, DFS used to show us half the story. Now, GRFS is not just the survival, but the how well the patient is living well, and this makes a real, and that's the whole purpose of allogenic stem cell transplant, the absolute quality of life without the toxicity of continued immunosuppression, as well as the suffering from the unending challenges of the chronic GVHD. So Dr. Karnat sir and Dr. Ragesh, would you like to make a call to a switch at 8 to 12 weeks in terms of these with consideration to GRFS as your ultimate goal?
So once we start for chronic GVSD, suppose there is progression in 4 weeks or even sometimes 2 weeks, I would add some other agent definitely. But otherwise, while we are tapering, I would wait for definitely for 8 weeks to decide to jump if there is deterioration in any organ score, or if at any dose above 0.5 mg per kg there is a decrease in the improvement on tapering. I would make a switch maybe at 4 to maybe at 8 weeks in general.
Yeah.
And lungs, as you already discussed, once it starts, it's a relentless course. Probably in the Rockstar data, if you we saw, there are few patients who achieved CR also, which is quite incredible for any drug, because we have hardly seen CRs with any medication for BOS. So for lung, maybe I would be more aggressive and inclined to change if I find the scores are worsening.
Yes.
Otherwise, I would wait and watch, use lot of ancillary treatment like eye drops, oral creams and ointments and skin creams. And I would do ancillary treatment liberally while I try to reduce the dose of steroids.
So thank you, Dr. Ragesh. So just towards the end, Dr. Kannan sir, with low rates of more than grade 3 cytopenia, minimum CVM signals, how does this influence, particularly as we saw the global trend as well as the Indian trend, more and more older comorbid patients are being taken up for matched sibling as well as haploidentical stem cell transplants who are quite infection prone and because of the age and comorbidity. So how does this influence your order of the CMV therapeutic intervention for chronic GVHD, the chronic GVHD therapeutic intervention in these difficult to treat patients? Will you be little, your threshold will be low to add any particular drug in these patients?
Meaning for GVH or infection?
Chronic GVHD, chronic GVHD.
No, no. So, speaking, based on the at least the data we have for Belumocidil, actually it looks wonderful compared to the kind of armamentarium we have. It is definitely an add-on to what you can do with chronic GVH. Quite effective. Even when we say that it is not effective in lung, actually we don't have a more effective alternative in lung GVHD. I mean, compared to the action of this drug on other organs, it is less effective in lung, but it's not as if we have a better option to do that in something like a severe lung GVHD. So our challenge, like usual and always, is going to be actually how to sort of get into our armamentarium without causing financial toxicity to our patients. So we can get it early on to the uh, earlier line of therapy, and also for in most of the chronic GVH, it seems to be effective. So the if the financial challenge is deferred, we could definitely add on for as a steroid sparer, as a more effective agent in most of our usual chronic GVHD. I can't sort of think of a situation where it is frankly we cannot use.
Absolutely. So
Seriously speaking.
yeah. So as this, I'm sure this is a signal to the Sanofi team for, this drug has immense potential, provided it doesn't, it doesn't add too much to the financial toxicity to the patient and their caregiver. So last question, Dr. Mallikarjun, Belumosudil, the sequencing and combos, will you opt Belumosudil after Rux ibrutinib or vice versa? And any role to pair with extracorporeal photopheresis in sclerotic disease, as you have good hands-on experience with belumosudil? So what's your real world threshold?
I think you and Dr. Kannan may have alluded to this before. We know that the approval is after 2 lines of systemic therapy. However, certain patients wherein we can prefer this, largely those who have sclerosing disease, those who have skin fascia, those who have significant cytopenia, those who have poor marrow reserve, those who are extremely ill, we have worried about CMA reactivation. All such patients, I think we could use this before the other agents. We need not follow the algorithm.
Absolutely. So this is one of the promising endpoints, the durability of response at 24 months, so almost more than 85% patients. So we all know. So this is a promising agent, and this is the last question and the most important one. Since the CDSCO approval in 2024, how are you integrating access, monitoring, and cost across the centers? All three of.
I do not know if I understand your question well, but the team of Sanofi has been helpful in few patients that we have used. I think they have their own ways and means to help patients with assistance program. And in terms of access, once patient goes through all of that, the drug comes quite fast.
Yes. So any specific monitoring for the last, audience take home message?
In regards to monitoring, in regards to
For belumosudil, any alarming, adverse events, and you will like to monitor particularly in that regard when the patient is on belumosudil?
We do the
Mallikarjun?
liver and renal functions initially. Once we initiate 1 to 2 weeks, and then once in 4 to 6 weeks is what we have been following.
Absolutely. Thank you so much. So this is NCCN management again, as highlighted. Belumosudil is one of the FDA approved agents in the order after ibrutinib. And with that, I conclude for years we have controlled inflammation in chronic GVHD, but watched fibrosis slowly taking over and stealing the functions of involved organs. Probably Belumosudil is the first time many of us feel we might change both lines of that story. And thank you, Malikarjun, Dr. Kannan sir, and Dr. Ragesh for bringing out the the day-to-day practical tips and valuable insights on chronic GVHD management with particular emphasis on Belumosudil. Thank you, Team Sanofi, for bringing all of us together on this virtual platform. We are all grateful to MHG for continuing the legacy of such educative platforms for all the hematologists and transplanters across the country. With that, I conclude. Thank you so much, and we are bang on time.
Thank you, Ganesh.
Thank,
Thank you, Dr. Kannan and Dr. Ragesh.
thank you, sir. Thank you.
Thank you, Dr. Ganesh, and thank you all the panelists. We are dot on time, and now we'll go with our second guest speaker. Let me share the screen. So the part 2 of our webinar today. Your second guest speaker, we have Dr. Mohammad Rizwan Sheikh from Mumbai. Let me introduce Dr. Mohammad Rizwan Sheikh to all of you. Dr. Mohammad Rizwan Sheikh completed his MBBS from LTM Medical College, Mumbai, followed by MD Medicine from St. G.S. Medical College, Mumbai. He specialized in clinical hematology, obtaining a doctorate NB from National Board from the prestigious Rajiv Gandhi Cancer Institute and Research Center, Delhi. He has deep interest in the field of hemato-oncology and particularly in the treatment and management of acute myeloid leukemia and bone marrow transplant. He has contributed extensively to the understanding and application of individualized AML induction therapy based on patient fitness, and his key contributions include venetoclax in AML published in the American Journal of Hematology in 2021, individualized induction therapy published as an abstract in ASH. As a research consultant to ImmunoAct, he also contributed with leading clinicians across India to improve overall outcomes in CAR T cell therapy. His work is widely recognized in international journals with multiple publications on cutting-edge treatments and emerging therapies in the field of hemato-oncology. His commitment to improving patient care, both through clinical practice and research, continues to shape the future of hematology in India. Today he's with us and he's going to lecture us on intensive chemotherapy with venetoclax in newly diagnosed acute myeloid leukemia. Well, I stop over here. Over to you, Dr. Rizwan Sheikh.
Thank you so much. Thank you for such a wonderful introduction. I don't think I deserve very comprehensive introduction as mentioned by you. Thank you to MHG for this opportunity. I'm just sharing my screen. I hope it is visible.
Yes, visible. Can you please make it full screen mode?
Yeah. Is it visible now in the full screen setting?
Not yet.
Okay. Uh, Now?
Yes.
Okay. So basically, intensive chemotherapy with venetoclax is something that is very close to my heart, and we've been working in this field since last 5 years. So before we jump on to the combinations of intensive chemotherapy with venetoclax, I think we'll have a brief overview of what currently stands at the as a management standard in India and the standard of care and how we are dealing with it. So, this is a question which I generally ask across all our talks, and mostly what percentage of the AML patients in India survive beyond 3 years? And mostly the answer is somewhere around 30%, because that is the data which is published in India across, the centers in North India as well as centers in South India. But the real answer, if you go and we have a deep down into the, data, and then we'll see how do we stack up. So if you look at this data, this is from AIMS Delhi. It was a data of 480 patients. It was published in 2015 by Dr. Ankur Behel. So the induction mortality is somewhere around 18.4%, and the CR rates is somewhere around 70%. And there is by the median follow-up of 34.5 months, we see a median overall survival of 20.6 months with an estimated 5-year survival rates of 35.5%. So this is the data of young and fit patients who were able to get treated at AIMS. Now, if you look at southern part of India, this is from Adyar Cancer Institute, Chennai, and even here this data is of 93 patients. The induction mortality is somewhere around 17% with the CR rate of 60%, and the median survival around 2 years is 30%. So this is where mostly data will point out to somewhere around 30% survival. Now, if you look at this paper from Dr. Chepsi, which was published from CMC Vellore, they found out that out of 380 patients, 271 did not take the treatment, and so that's around 71%. And the induction mortality is somewhere around 27.1%. And most of the common causes of induction mortality is because of sepsis and fungal infections. And another study by Dr. Ragesh was there in the panel discussion just before this talk. During his days at AIMS, there was an EHA poster which he had submitted, and this had 268 patients who were screened, out of which 46% had baseline infections, and 50 out of the 124 patients who were not able to receive therapy. So this is something that is alarming. The patients who had baseline infections, almost half of them have present to a tertiary care with infections, and out of them a lot of patients are not fit for therapy. So if you look at from that point of view, we see that a lot of patients are not able to undergo therapy. Now, if you look at this data, this is from the Hematology Cancer Consortium, which is the registry doing pretty good work in collecting data of AML patients treated across many centers. Now, if you look at this data also, we see that 392 patients who were treated with 3+7 with young fit patients, the CR rate is almost 52.8% and the mortality is somewhere around 16.9. But some centers are reporting the mortality as high as 43%. And the most common cause of mortality is multi-drug resistant organisms, that is 24.5% of them. So if you look in the complete entirety of picture, you will see that if there are 100 patients who are diagnosed with AML in India, 70 won't take treatment, right? 30 will take treatment, like some 30% of them will take treatment. And out of that 30%, 30% will have something like long-term survival. So if you look at overall in India, we are curing or treating and patients living more than 3 years in AML, it is hardly less than 10%. So this is the need why we need to have our own protocols, we need to develop our own strategies, and we need to be very, very sure about what we are doing, and come up with solutions which are very India specific. So the next part of my talk will be the amount of data which we have collected and the publications which we have done in this field, with the plain goal of having reducing the induction mortality and improving the efficacy. So the journey begins actually when I was in residency in Rajiv Gandhi, Delhi, and we started collecting data on venetoclax-based inductions. So so just a few slides on venetoclax. It's a BH3 mimetic, acts by inhibiting BCL2, and it causes apoptosis. And as a single agent, it did not demonstrate a lot of activity. There was only 19% activity as a response that was published in Cancer Discovery back in 2016. However, the data from Courtney DiNardo of comparing it and as efficacy of venetoclax with azacitidine in elderly patients who were untreated before, the CR rates were somewhere around 60 to 65%. And then we all know, then later on it got published as Wiley. But when we had that data and before Wiley got published, it was published in 2020. In 2019, we were treating some patients with Azaven, and the experience of 2019 of treating patients with Azaven is as listed. So we had 32 patients who were treated with azacitidine and venetoclax, and this was given to patients who were not fit for induction chemotherapy by 3+7. And at that time, we had out of this small subset of 32 patients, 60% of them were females. Median age was 58 years. and 40% of them had ECOG performance status of more than 2. And we had 16 patients who had previous stay. So that means that they were so sick that they required ICU stay, and then once they were stabilized, they were shifted to they were started on this therapy. And this ELN 2017 classification, according to it, almost 40% of them were standard risk, 40 were intermediate, and around 20% were adverse risk. So at day 28, we were able to achieve 63% CR rates, that is composite CR, and at day 56, we were able to achieve 66% of CR rates, and the induction mortality was 1. So this is pretty staggering that the induction mortality reported with intensive therapy is somewhere around 25%, and with ASA and when we were able to reduce the induction mortality to up to 3%. And if you look at 1 year OS, it was 76%, and 1 year PFS was 66%. So we were actually, in those days blown by the less toxicity which ASA-Ven used to have as compared to the intensive chemotherapy, because we were having a real hard time treating patients with 3+7 at that time. So the question we had that time was, can we reduce the dose of venetoclax and in Indian patient, and can we further reduce the toxicity which we were experiencing? So we collected data through 2019, 20, and 21, and this publication was published in 2021 in American Journal of Blood Research, where we compared data of less than 21 days duration versus more than 21 days duration with venetoclax. And we found that the response rates were similar. There was similar severity of myelosuppression. There were early count recovery and lesser duration of IV antibiotics. So with ASA-Ven for Indian patients, we found out that lesser days of venetoclax would be also feasible. Obviously now there are multiple data from multiple centers, and now we know in 2025 that okay, less number of days of venetoclax is also doable. But this was back in 2021 when this was an original idea which we had developed by observing patients. This was actually born out of that a lot of patients were not able to afford 28 days of venetoclax, so we were giving them lesser days of venetoclax. And then ASA-Ven data was published while was, I think, everyone in the panel and across different parts of the country who are watching this webinar must have gone through this paper. And this had around 431 patients. It was an RCT with a median age of 76 years. And at a median follow-up of 20.5 months, the median of survival was 14.7 months in ASA-Ven group versus 9 months in the single agent ASA group. And then there was this study which was published from the Australian group that you can combine chemotherapy, the intensive chemotherapy with venetoclax, with the sole purpose of improving the efficacy of the induction therapy. And obviously, 3+7 did not have such bad induction mortality in Western countries where the supportive care was good, and they did not have that much problem of MDRs. So they treated 51 patients of AML with age more than 60 years, and they reduced the 7+3 to 5+2, and they gave 14 days of venetoclax. And the striking thing was, when you combine chemotherapy, intensive chemotherapy with venetoclax, the overall response was 97%. This is like something which was unheard in AML before. And later on, multiple groups like the Chinese group also published one data of 7+3 plus venetoclax, and then multiple papers were there. But the initial idea of combining chemotherapy with venetoclax was discussed in this paper. So we thought, why don't we also try to do that in younger patients who were fit? So we did give 5+2 plus venetoclax to our patients in 2020, 2021, and we treated around 15 patients with this protocol with the median age of 48 years, and almost 40% of them had poor ECOG performance, who were not fit for the actual 3+7. And again, we had similar numbers that ICU stay, 5 patients required ICU stay before starting this therapy. And we had only 2 patients of standard risk in this case, almost 60% were intermediate, and 3 patients, that is 20% of the patients were adverse risk. And at day 28, we were also surprised that 83% patients had achieved CR or CRI, whereas at day 56, it was maintained, and the induction mortality was still low. However, with even lower induction mortality, the problem which we faced was these patients had continued to have severe infections. So this was something which propelled us to further the quest for getting a better therapy for AML was there. Then the question was, can we use ASA-Ven or abbreviated 3+7, that is 2+5 venetoclax, in our younger and unfit patients instead of just older patients. So this was an ASH abstract which we published. That was individualized AML induction with venetoclax based therapy in unfit treatment naive patients who are aged less than 60 years. So in this, what we did was we considered two group of patients, group cohort A and cohort B. The cohort A is patients who received azaven, and cohort 2 is patients who received cytosar plus venetoclax, and daunorubicin doses was individualized based on their fitness. So someone who was otherwise fit was received 2 doses, but who had severe infection not responding within 48 hours received 1 dose, and those patients who were in the ICU or who were on supports were not given any doses of daunorubicin. This was also inspired by the YLSC study, which gave cytosar plus venetoclax, which also underlined that even that combination is pretty effective. So there were 12 patients in cohort A and 14 patients in cohort B, and the median age was around 55 in cohort A and 51 in cohort B. Overall, they were pretty sick patients. So if you look at baseline infections, almost 70 to 80% of the patients had infections in both the arms to begin with. And if you look at the ELAN risk classification, almost 20% of them were adverse risk in both the arms, and almost 40 to 60% were intermediate risk. So with this bad, difficult to treat patients, they were either given azaven, and if they were considered fit enough to undergo abbreviated therapy, they were given 3+7. This was something which was based on physician discussion. The protocol is then the cohort A, azaven was given as a standard protocol, and this was preferred in patients who are unfit for intensive chemo. And patients who are in cohort B received cytarabine infusion with venetoclax, and dono was added based on their fitness. And they were given for the period of up to 7 days to 14 days based on the tolerance of the patient. Now, the problem with this was, overall, we continued to see that these patients who were receiving intensive care therapy, the infection, specifically colitis, if you can have a look at the last column here, the grade 3 to grade 3 colitis was seen, in 4 patients here, and then they had cellulitis, perianal infections. So this was there with resistant organisms. So this did not really, even though it improved the CR rate, but the induction used to be still like a roller coaster ride, and patients used to still have severe infections. Then if you look at the efficacy wise, the cohort B did borderline better. At day 56, 75% CR rates in cohort A versus 85% in cohort B. Although there were more patients, when we followed up for a long period of time, we found that the patients with cohort B are having a flattening of the curve after 1 year. So we found out that azaven patients are not having as durable responses as patients with intensive chemotherapy plus venetoclax. However, the toxicity was still a limiting factor for us. So then the quest to increase the efficacy of induction now, because the induction modality has been reduced, was still ongoing. And then this paper was published by MD Anderson, that combining FLAG-IDA with venetoclax as an induction and consolidation in patients with AML in frontline as well as in relapsed refractory setting. So if you look at this data, there were 29 newly diagnosed patients. The CR rate was 97%, which was again a very, very superior result. And the second most important point is that the 1-year OS was 94%. So this is, again, it was something which was very mind-boggling, and it was something which we never expect in our AML patients. And then grade 3, 4 adverse events were more than occurring in more than 10% of the patients with febrile neutropenia. That was almost half of patients had febrile neutropenia. But it was not adaptable to India because we already had very poor experience with FLAG-IDA as a general protocol without venetoclax. And the amount of neutropenia that happens with FLAG-IDA is too much to handle for our patients, specifically with MDR organisms. So even in this paper, they had cycle lengths exceeding 40 days. That happened, and it kept on increasing with every cycle. So in the first cycle, it was only 19%, but it went up to 59 to 50% of the patients having more than 40 days cycle lengths. That is, the duration of neutropenia was pretty high. So it was not adaptable to our settings. So we tried to remove the idarubicin, and we conducted a study where we gave flag-based versus with venetoclax versus standard 3 plus induction therapy in our patients, and this was published in 2023 in Leukemia Research. So the idea was to develop a protocol which does not cause anthracycline-based toxicity, and this is a data of 37 patients with more than 18 years of age with performance status of less than 2. So the newly diagnosed patients were either given 3 plus 7 or flag with or without venetoclax, and the decision to administer that was actually as per physician's discretion. So the treatment protocol is that the standard 3 plus 7, that is the group 1. The group 2 had fludarabine for 4 days, 30 mg per meter square. Cytarabine, this is dose reduced to 1500 milligram per meter square once daily for 4 days. And filgrastim was given at 5 micrograms per kilogram, subcut once a day from day 1 till the patient develops absolute neutrophil count of more than 500. And venetoclax was given in the ramp up fashion, 50 mg for day 1 and 2, followed by 100 mg once daily. And it was given at a median of 7 days. Now, just to draw the difference in this protocol versus the existing protocols. So, if you look at the traditional flag IDA, it has fludarabine for 5 days, idarubicin 10 mg per meter square for 3 days, and Ara-C is 2 gram per meter square for 5 days, right? And when you look at flag IDA Ven protocol, which was used by Courtney Dinardo and team in the MD Anderson paper, fludarabine was 30 milligram per meter square for 5 days, but they had reduced the dose of idarubicin. So it was 8 mg per meter square for frontline and 6 mg per meter square for relapse patients. Whereas Ara-C dose was 1.5 to 2 grams and it was for 5 days. What we did was we made fludarabine for 4 days. Ara-C was made for 4 days, but the dose reduced for 1.5 gram per meter square. And venetoclax was curtailed to only 5 to 7 days, and now we are giving only for 4 days. Now, if you look at the baseline characteristics, they are almost similar in both the groups. The p-value is not significant for any of the factors like age, sex, PS, adverse risk, comorbidities, and others. And if you look at the safety profile, now this is the thing which is very highlighting this protocol. So in this, if you look at the mucositis, it is less in the flag Ven group. The diarrhea is less. The overall duration of neutropenia is very, very different. So 3 plus 7 had 22 days plus minus 6 days of neutropenia, whereas flag Ven group only had 15.7 plus minus 5 days of neutropenia. The duration of hospital stay was also different. The days of antibiotic therapy was less. The overall third line antibiotic usage was less, 76% to 36%. The way we defined the antibiotic usage was first line was cephalosporin sulbactam, second line was meropenem, third line was meropenem plus colistin or polymyxin. So the use of colistin had reduced in this group of patients, and overall the overall tolerability of this regimen was much better than 2 plus 5 plus venetoclax. Now, if you look at the efficacy, so we found that the CR rates of up to 90%, that is 89.4%. This was another thing which was never heard in Indian patients. 85% MRD negativity by flow. We did not have any induction mortality, and the median survival by the time of analysis had not reached. We had 1 year overall survival of 87.5%. Now, this was pretty exciting, and this is the swimmers plot, which is showing the different groups. So, orange group is the flag-based therapy. Only 2 patients underwent transplant. And the blue one is the 3 plus 7 therapy where 3 patients underwent transplant. Overall relapses, if you look at the follow-up day up to a year, we did see only 1 patient in flag Ven based therapy relapsing. However, we experienced 3 relapses in patients who were given 3 plus 7. Now, if you look at the overall survival, obviously flag Ven does much better as compared to PFS. And so we wanted to take this further, and we continued to collect data, and this is the data which we have sent to this ASH. It was accepted for presentation as a poster this year. It's flag Ven as a frontline induction therapy for AML, and it's a multi-center experience of anthracycline-free approach from India. So this is collaboration between 3 institutes in India, and the data is with the longer follow-up. Now we have 44 patients. The median age is 40 years. And as per the ELN 2022, standard risk 23% of the patients, intermediate risk 41% of the patients, and we did have 30% of the patient as adverse risk. In this cohort, we had 0 induction mortality, The CR rate at day 28 was 93%. The 3 patients who did not respond had 2p53 mutations and complex karyotype. The transplant rate was 32%, which is, I understand, pretty high as per the Indian standard in real world. But these centers were able to convert most of the adverse risk patients to transplant. The 1-year PFS was 76% and the 1-year OS was 92%. So these are the PFS and OS curve. This is something which we don't usually see in AML settings in India, and we were very surprised, by this kind of results in a larger population in India. So with this, I would like to just give some take-home messages that the data presented is non-randomized and also the sample size has been small, but it does focuses on an effort on a continuous improvement in AML outcomes and in the current Indian settings, because we cannot replicate intensive therapy protocols from the West because they have different settings, different MDR exposures, and different antibiotic usage and different tolerance. However, from Indian point of view, I think it is less is more. Combining flag with venetoclax may be one of the ways by which we can combine venetoclax with intensive chemotherapy with less overall toxicity and with better efficacy. And we do need a larger study, like a phase 3 RCT based study in India, to exactly understand how to best treat AML with our current challenges of MDR organisms, poor accessibility, and financial toxicity. This is our team from RGCI and other cooperating centers. Happy to answer questions. Thank you for your attention.
Thank you, Dr. Mohammad Rizwan Sheikh. Wonderful lecture, wonderful talk, and good to learn from you. Thank you so much. And I now request our discussants to please put the hand raise sign so we can start some questions session with Dr. Rizwan Sheikh. Yes, Dr. Sunil Jodale, your question.
No, sorry. Just I'm preparing for next. I don't have a question. Sorry.
Okay. There was one question for Dr. Mallikarjun Kalashetty. Are you there, Dr. Mallikarjun? He's left, I think so. Yeah. So anybody has any other question? Because we still have time. So next is on. So would you recommend adding venetoclax to your induction protocol?
So yeah, we do that. I think I do that routinely for our patients. The standard treatment which we follow currently is flag-ven rather than 3+7. So this is the abstract was I think analyzed in August, but now we have some, I think that was 44 patients, but now we have 61 patients who have undergone this therapy. And with time, with a longer follow-up, I think the picture will get clearer. But so far, I think it's been good 3 years of follow-up, and we are not seeing a lot of relapses or a lot of adverse signals. So the strength of this protocol is that it is maintaining its efficacy signal also, and it is also maintaining its safety signal. So I think major problem which we have is induction mortality, and I think we are not seeing that much. That is maybe because we have dose reduced a lot coming to from the standard protocol, and the transplant rate also in the cohort is higher as compared to other usual reported studies. I think these are two factors which we should be considered before replicating it. But overall, this data and this protocol has been also followed by other centers, which is not included in the studies, but in this study. But most of the people have reported favorable protocol. Even in a public health setting like KEM hospital, we have done this protocol, and all the patients who we have done this protocol are almost all of them achieved remission, and none of them had induction mortality. So this is something which is not limited to very good centers with a lot of good care. Like for even in a public health hospital like KEM, which is we have limitations just with the nursing care and the infection care, and they don't have separate rooms to stay. So yeah, generally our patients have small cabins to stay. But even in those particular settings, even in a public health settings, we were able to deliver this protocol with good results. So I think in any patient who's fit for induction chemotherapy, uh, we should, although very early, we only have 3 years of data, but still, uh, it is something which should be pondered upon at least before starting induction therapy to any patients. I think it deserves it.
True. Thank you so much.
Thank
And
you.
since there are no more questions over here, we'll move to the third guest speaker. So thank you so much, Dr. Mohammad Rizwan Sheikh. Wonderful lecture. We learned a
Thank
lot.
you.
Thanks a
Thank
lot.
you.
And now let me share the screen again. So let's go with the part 3 of our MHG webinar today. And our third guest speaker is Dr. Sunil Jodale from Raipur. Let me introduce Dr. Sunil to all of you. He's Associate Professor, Department of Pediatrics, in charge, Pediatric Hematology and Oncology at AIMS Raipur, Chhattisgarh. Today is with us and is going to lecture us on approach to bone marrow failure syndrome. Well, thank you so much. I stop over here. Over to Dr. Sunil.
Dr. Amit, can you please enable the video? I think I'm not able to see this.
You are
So
not able to?
video, I think video is disabled from your side.
From my side? Oh, no. Nikhil, right? Just
Yes, sir. I'm sharing the screen.
So I'm sharing screen by my side. Is it visible?
the video is disabled from his part. Can we do anything from our side?
Just hold on.
Why his video is disabled? Have our settings?
Okay. Start
Yeah,
my video.
yeah.
Is it there?
okay.
So is my slides are visible?
No, not yet.
Not yet.
Okay. Okay, wait, just. I'll share again. Okay, is it visible now?
Yes, visible, very clear. Please go ahead. Can you make it in full screen mode once?
Yeah, sure. Now I'm audible and slides are visible now.
Yes.
Yeah. Okay. So good evening, everybody, and thank you, MHG, Dr. Agrawal sir, Dr. Kamit Khurana, for this opportunity. So I'm going to speak on approach to inherited bone marrow failure. So this is mainly the diagnostic approach. I'm not going detail in the treatment part. So as I'm additional professor at AIMS Raipur, I look after pediatric hemato-oncology here. So inherited bone marrow failure syndromes, they are being said to be like either there is a quantitative or qualitative abnormality in the bone marrow, either a series of erythroid, myeloid, and megakaryocyte lineage, and they lead to anemia, leukopenia, thrombocytopenia, or a combination of both, or it may lead to pancytopenia. I know, and these are the very heterogeneous group of rare disorders, and diagnosis almost take many time, sometime weeks to months for confirmation diagnosis. And there is significant overlap between clinical and some degree hematological manifestation of various bone marrow failure syndromes. And some may present solely as hematological abnormality and complication due to peripheral cytopenia, and other may have high incidence of skeletal abnormality as well as increased risk of hematological malignancy and or solid tumors. So this is the key characteristic of inherited bone marrow failure. They have present with cytopenias, they have congenital anomalies, and they predisposed to malignancy, and occasionally they can present in the adulthood also. And largely they have genetic defect mainly in the DNA repair, telomere biologies, ribosome biogenesis, and transcription factor pathways. But all of them have a common pathophysiology, that is low apoptotic, threshold of mutant cells. That the cells die very easily compared to the normal cells. And this is the broad, genetic defects in most of the inherited bone marrow failure syndromes, which include DNA repairs failure in Fanconi, and then transcription factor deficiency in GATA2 deficiency. Then we have telomerase biology disorder like DKC. And then we have ribosome biogenesis and processing disorders, which include Diamond-Blackfan anemia, Schwarzman-Diamond syndromes. And we can classify based upon the pathological and biological basis. They like either ribosomopathy, which include these 4 disorder like Diamond-Blackfan anemia, Schwarzman-Diamond syndrome, DKC, and cartilage hair hypoplasia. Then we have Fanconi's anemia, which mainly has a DNA repair. And then we have mitochondrial disorder, which can present again cytopenias and bone marrow failure syndrome, which include Pearson syndrome and reticular dysgenesis. Telomerase pathy, as we know, most commonly we see DKC, but there is a defect of telomere in Fanconi also, and Bloom syndrome. And we have transcription factor deficiency, most commonly GATA2 and rarely GATA1. And then we have commonly we see severe congenital neutropenia. Then particularly thrombocytopenias are seen in AMKL or megakaryocytic thrombocytopenia and TAR syndrome. And we have this fantastic disorder CDA, where there is dyserythropoiesis. So they can also be classified based upon the predominance of cytopenias. So either maybe there is red cell cytopenias like anemias predominant symptoms like we see in Diamond-Blackfan anemia, congenital dyserythropoietic anemia, and Pearson syndrome. Or there may be predominantly thrombocytopenia seen in these 2 disorders like CMT and TAR. And there may be predominantly neutropenia, which seen in Schwarzman-Diamond syndrome, severe congenital neutropenia, and severe form is also known as Cosman syndrome. And then we have GATA2 deficiency. And then lastly, there may be syndromes which may present multiple cytopenias, the most commonly Fanconi's, DKC, and reticular dysgenesis. So when to suspect inherited bone marrow failure syndrome? The first clue comes from the persistent single cell or pancytopenia. There may be some children who present with the MDS, then particularly malignancy like acute myeloid leukemias. And then we see some specific clinical phenotypes or congenital anomalies and multiple syndrome-specific anomalies like Fanconi's or DKC. And then if there is a family history suggestive of inherited bone marrow failure syndromes. But remember, diagnosis of inherited bone marrow failure syndromes may not be very, very clear cut, and it may be diagnosed during a specific evaluation of aplastic anemia without any congenital anomalies, and particularly based upon the genetic studies. So these are some of the defects we see in this inherited bone marrow failure syndrome. You can see that the thumb abnormalities, extra thumbs, you can see the particular faces, this capsulate spot, tongues, coated tongues, seen in various disorders. So we start with those who have pancytopenia. We start with CBC, looking at hemoglobin, WBC count, platelet, and particularly if there is no splenomegaly, we look for the peripheral smear. If there are no blasts, no abnormalities except cytopenias, we go for a bone marrow aspiration and biopsy. And if there is a hypocellular marrow, particularly the cellularity is less than 25%, it may be classified as either acquired aplastic anemia or inherited. So inherited bone marrow failure syndromes, this includes most commonly Fanconi, DKC, Schwarzman-Diamond, inherited thrombocytopenia. So these are the differential diagnoses which come in our mind. So this is how we go. We first establish the diagnosis and severity, rule out inherited. This is particularly in pancytopenia or cytopenias. And then we rule out inherited bone marrow failure and other genetic cause and look for the specific cause and association. So these are the tests we do, like CBCs, which may be pancytopenia. There is macrocytic anemia, which is very commonly seen in almost all the inherited bone marrow failure syndrome, and there is reticulocytopenia. So these 3 clues gives most of there is inherited bone marrow failure syndrome, and PS, which rule out if there is no blast or dysplastic cell. And we see the severity based upon this Kamitas criteria, and rule out the inherited bone marrow failure syndrome with by looking at the bone marrow failures, like bone marrow, which is aplastic anemia, and mainly we go for a karyotyping, fish, and NGS test, which finally can establish the bone marrow failure syndromes. But we have to rule out other common like viral infection, nutritional deficiency, PNH particularly. And once we this rule out, once we get a genetic test, HLA testing has to be done, because we know the treatment of the most of inherited bone marrow failure syndrome is a transplant. So this is how we go. So any aplastic anemia with two cytopenia with hypocellular marrow, particularly if they are severe and very severe, we should go for a NGS and SNP array, and mostly we can diagnose the inherited bone marrow failure syndrome based upon this test. Why the NGS? Because there are particularly many genes which can genetic disorders and genetic mutations which can with the inherited bone marrow failure syndromes, and identification of underlying cryptic or unrecognized inherited bone marrow failure syndrome patient aplastic anemia has a treatment implications, and conditioning regimen differ for this bone marrow failure syndromes, and they not respond to immunosuppression therapy, because somebody, if you do not do the NGS and they just keep on treating with immunosuppressive therapy, and they does not respond, may respond have additional side effect. And these children need monitoring for the cancer predisposition and other organ dysfunction also. So this is, there is lot of overlap between, inherited bone marrow failure syndrome, myelodysplastic syndrome, aplastic anemias, PNH. So we need to be approach these syndromes very carefully. So after CBC and retic count, we should review the peripheral blood smear, detailed family history, particularly if there is anyone has a bone marrow failure syndrome or died because of it. Careful physical examination, looking for the particularly microcephaly, tongue, limb changes, and then capsulate spot, which are commonly missed. And once we suspect, we should go for this particular test, which I will discuss in next slide. So start with the screening test, Fanconi's anemia. The screening test is basically chromosomal breakage study, which either DEP or mitoten based. And if it is positive, we should go for a confirmation test, which include NGS consisting of 90 gene panel. But again, it is, some gene may not be covered, but most commonly we see 65% case fancy. And then if we are suspecting telomere biology disorder, particularly DKC, the telomerase length in leukocyte subset is the screening test to begin with. And then once it is positive, we can go for a 14 gene panel for telomerase and cedrin components. If you are suspecting diamond blackfan anemia, which presents with isolated anemia in particularly infancy, then the screening test is erythrocyte adenosine deaminase and bone marrow erythroid hypoplasia. And then we should go for NGS to cover the common DBS genes. If you are suspecting diamond blackfan syndrome, if the child is more than 3 years, pancreatic isoenzyme is the screening test. If the less than 3 years old, serum trypsinogen can be done. And if you have cytopenias and pancreatic involvement, this 4-gene panel can cover most of the diagnostic test. If the child presents with a persistent severe congenital neutropenia, bone marrow showing promyelocyte arrest, this is the basically screening test, and then should go for a severe congenital neutropenia panels, mainly in the GNA. Then if your child has a persistent thrombocytopenia without any congenital anomaly, CMT is the likely diagnosis. The child, we should go for a bone marrow aspirate which show absent or few megakaryocytes, and genetic mutation shows MPL gene mutations. And remember, if you all the negative targeted bone marrow failure syndrome sequencing panel, which include whole genome sequencing, may be needed in some of the cases, because it is difficult to diagnose such cases. So we have some, we will discuss some of the syndromes, which is like present with predominantly with red cell dysplasia. Most among them is our diamond blackfan anemia, congenital dyserythropoietic anemia, and Pearson syndromes. Let's talk about diamond blackfan anemia. So the criteria of DBS is major criteria are presentation less than 1 year, child present with macrocytic anemia, there is a profound reticulocytopenia, and if the bone marrow is done, there is a paucity of the erythroid precursors. And the major criteria is either pathogenic mutation, particularly of that DBS genes, and positive family history. But we have some minor elevated criteria, which include elevated red cell adenosine deaminase, then congenital anomalies, elevated fetal hemoglobin. And if you there is persistent anemia only and there is no evidence of other inherited bone marrow failure, this may be also fall in the minor criteria. So we, based upon the criteria it fills, if they fulfill the 4 criteria, it is classical, and non-classical again DBA based upon the other 2 or 3 criteria we have to diagnose. So this is classically what we see in PBS. So there is macrocytic anemia and reticulocytopenia, and PS show microcytic pneumocomic cells. Bone marrow is normal cellular or may have mainly paucity of erythroid precursors and elevated erythrocyte EDA amynase. Adenosine deaminase is consistently specific as a sensitive test. And these are the genes because the final diagnosis based upon our genetic study, the most commonly, around 25% cases have this RPS19 gene defect. And remember, some of the 25% still are uncharacterized. So the diagnosis may not be confirmed in many of the cases. So they may be autosomal dominant or X-linked recessive. So this is the one of the our patient who has been diagnosed from NIH, and this has been RPL5 gene mutations. Next is with present with anemia is congenital dyserythropic anemia. This is again a very fascinating because these children mainly present with mimic like hemolytic anemia clinically because they present with splenomegaly, so it may be missed many a time. And they present with anemia, ineffective erythropoiesis, and morphological evidence of dyserythropoiesis. And some of the patients, they have hematological, non-hematological features like skeletal abnormality. And predominantly, they have a defect here from polychromatic erythroblast to this orthochromatic erythroblast. So this is the genetic defect, and you can see the defect in DB also and other disorders. So this is the classical presentation of this, CDA, which present like hemolytic anemia, reduced reticulocyte count, jaundice, splenomegaly. The children have, because of the transfusion dependence, there is hemosiderosis and gallstones, and they have erythroid hyperplasia compared to other disorder. They have hypoplasia. So these children, they have hyperplasia, but there is a specific morphological alteration involving the late erythroblast. And this is how we go, particularly if there is ineffective erythropoiesis and hyperplasia. Particularly, you have to look for the reticulocyte and hemolytic anemia like pictures. If this is there, so go for this pathway, and we can have a differential diagnosis of CDA, which includes CD1A, 2, 3, and 4, based upon their mutation and morphology. So these are the common problem in CDA type 1. So they have morphological body abnormality like skeletal malformation, syndactylity of hands, feet, absence of nail, and supernumerary toes. So morphology, there is a late erythropoietic nucleus and megaloblastic erythroid hyperplasia. So HEMPAS can also help to diagnose type 2 CDA, so which can stain this RBCs. Coming to the third syndrome is associated predominantly anemia is a Pearson syndrome, but this is a rare sideroblastic anemia type and associated with the exocrine pancreatic dysfunction, liver dysfunction, and renal tubule defect. But mainly it was in neonatal period, so hardly adults they have seen it, and it is characterized by macrocytic anemia. Occasionally they have neutropenia and thrombocytopenia, and they may have physical abnormality like retinopathy, ataxia, and muscle weakness. And they have failure to thrive also. The diagnosis is done histologically with calculation of bone marrow precursor. You can see in the slides. And they have defect in the mainly in mitochondrial defects, which include deletion and duplication of region of mitochondrial DNA. And the main thing in this Pearson syndrome is these children may have acidosis as a major component of disease, which look like a sepsis. And so we have to be very careful in a neonatal period. And this patient who survived neonatal period may have, but the anemia improves. So that's very interesting. And they may have endocrine dysfunction, which include diabetes type 1, adrenal insufficiency, hypothyroidism, and they may have, but there is no malignancy has been also documented with this disease. So coming to our next set of inherited bone marrow failure syndrome, which presents predominantly with neutropenia, and we have mainly 3 differential diagnoses, which include Swachman-Diamond syndrome, this congenital severe congenital neutropenia and Cosman syndromes and GATA2 deficiency. So Schwarzman-Diamond syndrome, again, we can diagnose easily if the patient has exocrine pancreatic insufficiency, inherited bone marrow failure, and some extra hematopoietic abnormality. So the diagnosis, particularly if there is metaphyseal dysostosis there, so diagnosis can easily be suspected. And pancreatic insufficiency is the hallmark of the disease. The patient presents usually with, sometime anemia and thrombocytopenia along with neutropenia. They have very high risk of infections, and the anemia can be seen in 20%, and they may develop MDS and leukemia also. And this patient may have wide array of physical findings, which include short stature, failure to thrive, skin rashes, and macules. And they may have palatal defect and syndactylity. The diagnosis of Schwarzman-Diamond syndrome is based on mainly clinical presentation of exocrine pancreatic insufficiency and bone marrow involvement. But diagnosis of this syndrome can be difficult because many of the patients do not have identified mutations, and the clue mainly come from this pancreatic isoenzyme deficiency. And we have to look for the pancreas by ultrasound, whether it's atrophic or not. So this is the picture we see in the bone marrow aspirate and bone marrow failure biopsy. Can see hypercellular marrow with increased number of small cells diffusely infiltrating the marrow, and then they may stain CD20 and other like defect can be seen. So I'm not going detail of this discussion, but they predominantly have a defect in this ribosomal pathway. So this where the mature ribosome doesn't form. So this is basically defective ribosal biogenesis leading to bone marrow failure syndromes. And we specifically get this classical SBDS gene, which is seen in exon 5 and 95% of cases, but some of the cases may have these defects, genetic defects also. Coming to severe congenital neutropenia or Cosman syndrome, many of you might have come across. This is very common cause. So this severe neutropenia is defined as the neutrophil count less than 500 lasting for more than 3 months. If the count is persistently less than 200, we say it is Cosman syndrome, which may associate with monocytosis and eosinophilia. There is specific maturation arrest of myeloid lineage at the promyelocyte and myelocyte stage. These patients have very high risk of having infections, particularly bacterial and fungal infections, and which again can be treated with GCSF. And this patient usually die of sepsis, and some of the patient may have MDS and AML as a cause of death. And bone marrow examination frequently show the maturation arrest in myeloid lineage, and some patient can present with cyclical neutropenia also. So these are the two various presentation. And apart from this, there is this patient have increased propensity of fracture because of the decreased bone density. And in most of the patient, there is heterozygous variant in the this ELN gene, and this ELN gene variant typically produce isolated neutropenia without any extra hematological abnormalities. So any patients with present with isolated neutropenia persistent, we have to look for these mutations. And this is, you can see the most common mutation is autosomal dominant, which is ELN gene. And but apart from this, there are others mutations also there, which is seen around one third, more than one third of patients. Coming to GATA2 deficiency, I'm sure adults must have come across, adult hematologist must have come across, or oncologist must have come across this GATA2 deficiency clinical syndrome. So this is autosomal dominant, which have more than mutations, and they may present with very right from early to later, more than 30 years. So most early they present with 0 to 15 years, they present with lymphedema and hearing loss. And in adolescent, they can present with infections, particularly HPV, non-tuberculous mycobacteria, various other viral infections like EBV, CMV, HSV. They may present invasive fungal infection and other bacterial infections. As the age improves, they may present with the myelodysplastic syndrome, pulmonary alveolar proteinosis, autoimmune diseases, and miscarriages in particular. And then more than 30 years, they have high propensity of developing AML and solid cancer also. So this is the classical presentation. These are 4 types, like we call it as monomac syndrome. So which present with monocytopenia and mycobacterium avium complex syndrome. Then we have dendritic cell, monocyte B and T, B and NK cell lymphodeficiency. Then they may present familial MDS or AML, and then primary lymphedema with MDS, which is called as Emberger syndrome. But GATA2 deficiency may present with isolated bone marrow failure syndrome. It may present MDS or primary immunodeficiency, or may present like first time as a AML also. So you can see this is the the pathway. So it can, most of the patients start with bone marrow failure syndrome or immunodeficiency syndromes. They progress to MDS and multiple dysplasia, which again can progress to AML, and some present can also present to CMML also. Coming to our third group of syndromes, the most commonly we have two syndromes which present with the isolated thrombocytopenia. Among them is most commonly congenital amegacrocytic thrombocytopenia, and we have thrombocytopenia or absent radius syndrome, also called TAR syndrome. So CMT, this is a rare autosomal recessive disorder. It is characterized by thrombocytopenia and absence or decline in the number of megacrocytic precursor in the bone marrow. And there is it is a compound heterozygous pathogenic variant myeloproliferative ligand gene defect, which code the receptor for hematopoietic growth factor thrombopoietin. There is impairing cell signaling and hematopoiesis, and this patient usually present with isolated moderate to severe thrombocytopenia, and the thrombocytopenia worsen as the age increases, and these children may eventually have pancytopenia. We recently diagnosed one of the case who presented with 4 year back. Initially, say present only thrombocytopenias, or we thought it like mainly ITP, and bone marrow was not done initially, but subsequently we did a bone marrow and found there is a absent megacrocytes, and we did a genetic study which found classically a CMT. So this patient, 50% patient may develop aplastic anemia by 5 years of age. So CMT, again, these children may have increased risk to MDS and AML. And in peripheral bleed, these patients have normal platelet size, and in a bone marrow there is a decreased megacrocytes. And TPO level can show a 10-fold increase from the normal limits. So TPO levels are elevated in these patients. We have classically three types of CMT. Type 1 CMT with severe and early onset thrombocytopenia, and type 2 CMT is milder and later presentations, and they have extracellular domain TPO receptor abnormalities. And type 3 is particularly there is no MPL gene defect, so there are other defects seen in type 3 CMT. So I think this is easily can be diagnosed. This disorder, what is called as thrombocytopenia absent radius syndrome or TAR syndrome. Classical child with infant present with thrombocytopenia have bilateral radial hypoplasia or aplasia with preservation of thumb, which is very classical. And these children may have some cow milk allergy. They present with diarrhea also, and they have classically absent megacrocytes absent. The platelet count in this TAR syndrome improve with infancy, and these patients have the classical mutation in this RMB8A, and but there may be some other like genetic defect like heterozygous variant of HOX111 and MECOMs particularly. This MECOM variant particularly can exhibit variable hematological phenotype, including progression to MDS and leukemia. And some MECOM variant have been associated with hematological abnormality, including global bone marrow failure syndrome in infancy. And there may not be some radioulnar fusion defect also in this MECOM variant particular. So these are the limb abnormalities seen in TAR syndromes. And this some of the differential diagnosis we go, but I'm not going details. So, but classically we have to see this genetic defect in CMT. CMT has classical this MPL gene mutation, and TAR has mostly this RBM8 mutations, and some of minorly they have HOXA11 MECOM mutations also. Lastly, we come to the syndromes which are associated with multiple cytopenias or cytopenia, and classically we have these three syndromes. The most common two are Fanconi's and dyskeratosis congenita. Reticular dysgenesis as such rare. We don't see much, and the Fanconi anemia is the most common inherited bone marrow failure syndrome, which characterized by physical anomalies, progressive bone marrow failures, and cancer predisposition. Most of them are autosomal recessive, but few may have X-linked recessive disorder also. And the presentation of Fanconi is very, very heterogeneous. Some present with early, some present in adolescents, some present, and some adults also. And many of these patients has extra hematologic abnormality, including this dermatological like capillate spots, skeletal like radial hypoplasia, genitourinary abnormality, gastrointestinal abnormality, and neurological abnormality. But remember, approximately 1/3 of the patient do not have overt extrahematopoietic abnormality. So you have to suspect Fanconi anemia even they do not have this physical abnormalities. So they may present only progressive cytopenias. So most of these patients are diagnosed at the end of first decades, and some patients are diagnosed in adulthood also. I'm sure we get a feedback after this. And this Fanconi cell display the hypersensitive DNA crossing agents like this diepoxybutane and mitomycin C. So this is the screening test we have discussed earlier. And there are proteins, which are a lot of proteins encoded by this in this order, which participate in DNA repairs. Till now, we have 17 complementation group defect which has been identified, and many more are coming up. So these are the somatic abnormalities which we see in commonly, which I already discussed. I'm not going details. But the main cellular abnormality in Fanconi's anemia is not only the defect in the DNA repair. They may have chromosomal defect, intrinsic stem cell defect. There may be direct defect in DNA repair and sensitivity to oxygens also. These are the multiple cellular abnormalities which actually present predispose these to Fanconi's anemia in a pathologies. So there are diverse, molecular functions in Fanconi's pathway, right from the ribosomal biogenesis, DNA repair, and cellular metabolism. So this is the commonly been, so they ultimately lead to genetic instability. So these are the some of the genes which has been identified. And remember, Fanconi's anemia is the not only one of the genetic defect with the chromosome instability. There are others like telangiectasia, telangiectasia, then Bloom syndrome, DNA ligase syndromes, and many more which present with the chromosome instability and can present with the bone marrow failure syndromes. But these are rarely we can see it. So malignancy risk is one of the key features of aplastic Fanconi's anemia. Most common malignancies acute myeloid leukemia, but head and neck malignancy are also seen. And this patient has 700 folds of increase AML compared to other patients, and the MDS is also very high. And particularly this, BRCA2 mutations, there is highest chance of developing malignancy, and they also has, high birth defect. While the patient with many defect are more likely to develop bone marrow failure syndrome. And the patient with normal physical appearance have a higher risk of developing acute leukemia and solid tumor as young adults. So this is the clinical approach for a suspected Fanconi's. We go for a chromosomal breakage test. And if there is no abnormal, classically, we go for a genetic test. If there is not very convincing, we go repeat this test and again see it again. If this is normal, we have to look for the other inherited bone marrow failure syndrome. But the genetic test mostly give a diagnosis. But we have to see the common mutation, particularly in Indian scenarios. So these are the listed most common Fanconi's genetic subtype, genetic defect. Most commonly you can see FANK-A, which is in 65%, and as you can see the CG also seen, and you can see this BRCA2, which is highly associated with malignancy in Fanconi's anemia, seen in less than 1% of cases. But some of the disorders may be autosomal. Apart from this autosomal recessive, there may be some X-linked on some autosomal dominants also, which is seen in this group. Coming to the last, commonest pancytopenia syndrome, which is dyskeratosis congenita, which is a triad of abnormal skin pigmentation, nail dystrophy, and mucosal leukopenia and leukoplakia associated with the bone marrow failures. So it is a major cause of mortality, and this patient also predisposed to cancer and pulmonary complications. So the classically we see aplastic anemia, MDS, acute leukemia, and pulmonary and liver fibrosis. So they again may be X-linked recessive, autosomal dominant, and autosomal recessive also. So there is an anticipation phenomenon classically seen in this syndrome, where there is increasing disease severity in succeeding generation because of the inheritance of short telomere, because telomere is getting shorter and shorter as the generation. So this is called as anticipation syndrome. And there are two categories of mutations found in DKC, that mutation that decrease the telomerase activity and mutation that impair the telomerase recruitment in gene such as TEN2. But there are some variants which in early infancy or early childhood, which viral Redson syndrome and Revesz syndrome. We have recently been diagnosed one patient who present with a persistent pancytopenia in infancy with neurological abnormality, which turned out to be this viral Redson syndromes. And these children may have up to 10% of patients may have malignancy, and majority of the cancers are carcinoma, particularly head and neck. So this is some of the classical presentation. You can see epiphora, dystrophic nail, dyskeratosis, this classical tongue, hyperpigmented tongue, and this is the patients we have recently diagnosed with inherited bone marrow, this DKC with dystonia and classical mutations. And what is the clinical presentation? I think this is very interesting slide. So you can see early, we can see this classical, these two syndromes, severe syndrome, and the classical DKC is seen in around first to around second decade. And subsequently, these children may have aplastic anemia. The cancer risk increases after 20 years of age. After 30 years, these patients mostly have MDS and AML. And around 40-50 years, they have pulmonary fibrosis, liver fibrosis, and osteoporosis, in late age. So these are some of the gene defects, sheltering, telomerase, etc., which are associated with in this defect. So the classical diagnosis is cytopenia with somatic abnormality, and 5% of patients have severe idiopathic lymphoblastic anemia also. The measurement of telomerase length in lymphocyte subset is the most early, critical screening test. And once it is done, we can go for NGS. So this very short telomerase length is most important, which have to see as per the age and the centiles. So measuring the telomere length in family member of DC patient is also important to identify the silent carrier as well as candidate for hematologic stem cell donors, because if this family member with match, if they have a very short telomerase length, they may not be suitable candidate for as a donors. And these are the genetic defects we see. Most commonly X-linked recessive, some of them are autosomal dominant and some of them are autosomal recessive, but some of them, most of them are 1/3 they are still uncharacterized. So lastly, this syndrome, the reticular dysgenesis, is extremely rare, which present with pancytopenia, again unital parade. They present with leukopenia and lymphopenia. They have proximal stem cell defect, and they particularly present with anemia and thrombocytopenia. So BMT has been curative in this patient, and they act like severe combined immunodeficiency most likely. So the inherited bone marrow failure syndrome doesn't end here. Some of the syndromes are still uncharacterized. So if these are, we cannot diagnose. We have to see the criteria, which criteria they fulfilling. If this one or two criteria does not fill any bone marrow failure syndrome, which we already discussed, and if they have family history of bone marrow failure, presentation less than 1 year, anomalies involving the multiple system, associated with cytopenia, reduced marrow progenitors, or reduced clonological potential of hematopoietic progenitor cells, increased fetal hemoglobin, and red cell macrocytosis. Macrocyte MCV is increased. Then we have to suspect the bone marrow failure syndrome, because they still some of them are uncharacterized and evolving. So this is the classical inheritance we see. They have somatic abnormality, bone marrow failure, short telomeres, cancer, chromosome abnormality, and these are the gene, various summaries of whatever we have discussed till now. And again, I'm now not going detail. So treatment, mostly we have supportive care, bleeding control, psychological progression of disease monitoring and malignancy evaluation, and definitive management is mostly transplant, except in androids can be used in Fanconi's. But most importantly, remember, the supportive care is the most important till the patient goes for a transplant. So we have to keep their HB more than 8, platelet more than 10,000. We have to give leukocyte depleted, irradiated, and CME negative blood products, neutropenic precautions to avoid the infections, then prompt treatment of febrile neutropenia, antifungal prophylaxis, iron chelation if if they are receiving frequent iron blood transfusion, and psychological supports. So I end my talk here with saying that the eyes cannot see what the mind does not know. So we have to know what bone marrow failure syndrome present to us, which can missed in during evaluations. So thank you, Dr. Amit and MHG team for this talk. I will be happy to answer any questions or doubts.
Thank you, Dr. Sunil. Wonderful lecture. Fantastic. You covered almost everything. And we have some questions from the audience. I'll just read the question to you. Dr. Rizwan Sheikh, are you there? Dr. Mohammed Rizwan Sheikh?
Yes, sir. Yes, sir.
Yes, Dr. Rizwan, please.
Yeah.
There are some questions for you. Let me finish the questions for you first.
Okay, okay.
Was yeah. So this question is from Dr. Hita B. When you are combining RSE with venetoclax, what is the dose of RSE?
So, RSE, if we are combining with venetoclax, then in the flag-ven protocol, we are giving 1.5 gram per meter square for 4 days is the dose of cytosar with the flag-ven protocol.
Perfect. Another question is from Dr. Karthik. If your endpoint is bone marrow transplant in IR as well as AR AML, that is intermediate risk and adverse risk AML patients, any difference in survival between flag-ven versus AZA-ven?
So I think it's a great question that if you are patients with adverse risk, whether you should give with flag-ven or AZA-ven. So the practical challenge we have is that in India, most of the centers are not aware of what is the cytogenetics and what is the mutations which the patient is having before starting therapy. So if you look at the data now, the flag-ven data, the CR rates are upwards of around 90% as compared to AZA-ven that is around 70%. So if a patient is fit, I think we should give the benefit of doubt to the patient and give intensive chemotherapy because it obviously has a better chances of achieving CR. Also, chemotherapy with intensive chemotherapy has a better chances of achieving deeper remissions as compared to AZA-ven because in AZA-ven, if you look at the actual CR rates, around 40%. The rest 30% is around CR with incomplete hematological recovery, that is CRI. So a composite CR actually comes out to 66.4% in the Wiley study, which is the same which we have noticed as well. But if we look at the actual CR rates, so what we're discussing with intensive chemo plus ven is actually the true CR rates, which is somewhere around upwards of 90%. Now coming to transplants, now this is a debate whether whether it matters or not, whether to achieve a deeper remission or not, because recently there has been a study which was published in Blood, I think this month itself. It's called ASAP study, wherein they told that rather than achieving remission, if you can directly transplant the patient, the overall survival depends on the disease biology rather than the remission which patients have. Now that brings us to another question, whether how good should the remission be. So example of a JCO study which showed that if a patient is in deep MRD negative remission, you can even get away with RIC transplant rather than myeloablative conditioning. So looking at it from that point of view, I think getting deeper remission, I would, if I don't know the cytogenetics of the patient, because if I know if it's TP53 mutated or complex karyotype, I might not choose intensive chemotherapy and I might just go with AZA-ven. But apart from that, we have seen that almost every other mutation responds really well to flag-ven. So we would, and in practically in most of the cases, we don't know the genetics. So it's better to, and a higher chances of achieving CR and a deeper remission. So would rather choose a flag-ven even in intermediate or adverse risk patients.
Thank you. And that is very clear. And I would like to agree with you because the first chance is the best chance. In India, because I think for the fit patient, what will happen if your AZA-ven patient doesn't respond to AZA-ven then? It's a big question. So apart from TP53, any other patient who is very fit other than that TP53. So you must go for flag-ven because these are the patients who want to be taken for transplant. But TP53
Yes.
is a big another issue.
Yeah.
Another question is from Dr. Hitha B. How to proceed after MRD negativity with FLAG1?
So what we have done in our protocol is that based on the mutation analysis, because by the time of end of induction, we are aware of generally the cytogenetics of the patient. So if the patient is core binding factor, what we have done is we have continued to give flag for another 4 cycles and added geo for 2 of them. And if they're MRD negativity, we do not do transplant them. We don't transplant them. And if it's MRD positive, after that we generally consider them for transplant. But apart from core binding factor, if there is intermediate risk patients whom MRD negative is not achieved, in those patients you consider for transplant. Adverse risk, we transplant almost every patient who has an adverse risk. Or in patients who are NPM1 mutations, patients who are only NPM1 mutations are different from the patients who have NPM mutations with myelodysplastic related mutations. So those really don't do as good as only NPM1 mutation patients. So those are the also patients which we transplant. So I think there are very less subset of patients in AML which we don't have to transplant. I think maximum of them, if they are eligible and if they have the good donor, I think we should consider for transplant. That is the only way we cure these patients.
Thank you. Another question is from Dr. Karthik. Do you wait for PCR or NGS before deciding whether to go for FLAG1 protocol?
So we don't wait, as I mentioned.
Perfect. Another question is from Dr. Raghunathan. What is your experience using venetoclax in TP53 positive AML?
So I think we have done around 100 odd patients of Azaven so far. Although I did not show you the data of entire 100 patients so far, but then in the RGCI cohort, around 100 patients done so far. With PP53 mutated patients, hardly the CR rates which we are getting is somewhere around 20%. But nevertheless, in those patients, if we are able to achieve cytoreduction, so if the patient has a partial response, also if the blast are around 7-8%, we've transplanted them with myeloablative conditioning. And we did find some patients who had a survival of around 1 to 2 years after transplant, but eventually they did relapse.
So those patients were transplant eligible.
Yes.
In TP53 positive, you are starting with Azaven.
Yes. As in
How many?
the patients who have achieved Azaven. The question was, I think, which patients who have received Azaven, if I've understood correctly, what is the response rate? So that is somewhere around 20 to 30%. I don't think it's more than that.
The question is only about the role of experience using venetoclax in TP53 positive.
Acha,
So if the
okay.
if
No,
patient
so we've seen in this entire 44 patients, 3 patients had P53 mutated AML and none of them responded. We did achieve in one of the patients, we did achieve a partial kind of response. We transplanted him, but he relapsed after transplant very early. So, and this is the one of the area where I think we need more therapies and more research has to go. It's very difficult to tackle them.
So whatever response we are getting is because of ESA, not because of venetoclax.
Yeah, so this has been obviously proven now, if, especially in MDS, when does not add too much of and adding it might not be helpful. And the trial has not worked. So in those patients who classify as AML, have blast percentage of 23-24%. Biologically, those patients are usually MDS, which is evolving into an AML rather than a true AMLs. And I think those patients are the one in which adding venetoclax or any sort of intensive chemotherapy might not be really helpful. So that is one area where we've tried if they are even having some amount of cytoreduction, transplanting them with MAC conditioning, that is something which might be of some help. Otherwise, I don't think there is real answer to this question as to what you should do and get the patient, cure the patient like in other AMLs.
So what about elderly patient who are TP53 mutation positive, not transplant eligible? Azaven, would you like to give Azaven in TP53
So that
mutation?
actually, if the blast percentage count is really high, I think as a when can be added. And if the blast percentage is very low, that's quite debatable as whether adding when is adding some amount of benefit to the patient.
Fine. Thank you so much. Question is for Dr. Sunil from Dr. Narendra Gemawat. Any clinical suspicious clinical presentation at birth in view of red cell dysplasias?
So, red cell dysplasia, they may present 50% may have congenital anomalies, and 50% may not have anything, and they present in our experience. I think we have seen quite number of the DBS patient, and they present isolated anemia, severe anemia without splenomegaly, reticulocytopenias. So the earliest clue is reticulocytopenia, macrocytosis, and severe transfusion dependent anemia. And some of the like 50% may have anomalies which may not be present in others. So just proceed for the genetic testing in any infant who present with this anemia, reticulocytopenia, and macrocytosis.
Thank you. That was the only question for you. So with this, there are no more questions from the audience and no more resident science. So with this, we come to the end of this webinar today.
Thank
And
you.
first of all, I thank all our speakers, starting from Dr. Mallikarjun Kalashetty, Dr. Ganesh Sheshetwar, Dr. Mohammad Rizwan Sheikh, and Dr. Sunil Chondwale for a wonderful lecture. We learned a lot from you. And I also thank all our panelists today who joined over here with the panel discussion with Dr. Ganesh Sheshetwar, all the discussions present over here, as well as all the audience. Thank you so much. That was a fantastic webinar and a fantastic lecture. Good learning, good question answer session. Thanks a lot. I will meet tomorrow again at 11:30 at 10 a.m. Tomorrow is, I think, 10:45 a.m. with another beautiful webinar. Well, thank you so much.
Thank you.
Thank you, sir. And very good lecture from Dr. Rizwan. I learned from Dr. Rizwan also.
Thank you so much. Same here, sir. Same here. Pleasure listening to you.
Good night.
Thank you.
Okay, bye-bye.